Good morning, everyone. My name is Aida Rodriguez, and I am the Behavioral Health in the Two Generation Clinic at UI Health.
Good morning. My name is Melissa Wagner. I am the psychiatrist. I am both trained in women's mental health and child and adolescent psychiatry. And I am the psychiatrist in the UIC Two Generation Clinic.
I am going to go ahead and start sharing my screen so we can start this presentation. Okay, so during this presentation, we will provide an overview of the clinic, or the Two Generation Clinic, as well as preliminary data that we have collected in our clinic. And we want to encourage everybody to use the Q&A function to ask any questions, and a member from our team, Dr. Liz Glasgow, will be answering those questions as we move through the presentation. We are also going to do our best to have some time in the end to answer any oral questions that you may have. Thank you. Before we get started, I want to read this disclosure, and I want to move my form because I can't read it. Okay. So we use through our presentation the word mom, woman versus person. While not all people who can be pregnant or give birth identify as being a woman, we use the term women instead of people or person as an intentional device to highlight the vulnerability of people who society typically identifies as being female. This is not intended to exclude or silence those who do not identify as female, but to draw attention to the ways pregnant and postpartum people are discriminated against because of their female sex assignment at birth. Currently, 100% of mothers in our clinic self-identify as women and use her, she as her pronouns. First, the Two Generation Clinic is funded through the HRSA State Maternal Health Innovation Program. The University of Illinois received a grant in September of 2019. As part of this grant, one of the innovations was to develop the Two Generation Clinic for postpartum families. So we'll start the overview on the clinic. The goals of the clinic is to increase access to early and regular postpartum care, to serve patients and families with limited resources and at risk for poor outcomes, to decrease maternal morbidity and mortality, and improve maternal health clinic outcomes. We currently have 2 locations in our clinic. Our first clinic opened in 2020 in the Outpatient Care Center, and the second location opened in December of 2021 in the South Loop Physicians Group. Now, the 2 stars in the map, as you can see, tells you more or less the area where our clinics are located. Our clinic serves some of the areas with the most underserved population, with high poverty rates, high levels of violence, low resources, and poor outcomes, health outcomes. The standard of care in our clinic, all mothers and infants receive comprehensive medical, behavioral health, and social care. Mothers and infants are scheduled together as a dyad. So the way that it works, we block 2 appointment schedules back to back, and that's how we're able to schedule them together with the same physician. That clinic opened up in an existing MedPeds clinic, and our physicians are double board certified as pediatricians as well as primary care providers. All the families receive wraparound care prior, during, and after the visit. And they receive behavioral health, social support, lactation care, and care coordination. The clinic also opened up recently for fathers, for older siblings, as well as other family members. This is a little diagram of our model of care. So I'm just gonna give you a few minutes to kind of look at the model, the diagram.
I can walk us through this, Aida. So,
Okay.
when the families, if they decide to join the two-generation clinic, there's a standard procedural of screenings that happen at minimum annually, including general health screenings, behavioral health screenings, violence and discrimination, including intimate partner violence, and PTSD screenings, family planning, developmental screenings that happen on the regular well-child schedule, and social determinants of health. And then depending on the results of those screenings, the care delivery you see in the middle, everybody receives primary care and care coordination. But depending on the needs of the family, they can be referred to behavioral health care, parenting education, lactation consultants, as needed. And then from a continuity of care perspective, we have regular touch points. So Aida and her partners are in almost constant communication with our families, especially our high need families. And they provide visit planning, patient follow-up, and clinical support for the families that join the two-generation clinic.
Yeah, I just wanted to add a little bit in the visit planning. We meet as a team every week. All the team members, which include the primary care physicians, the psychiatrists, OBGYN, nurse practitioner, social workers, care navigators, lactation. And we discuss all the patients that are going to come to they're scheduled to come the week. And it gets identifiable all the needs that they may have to create the best treatment plan for them. And also to, if you want to call it, assign somebody who's going to touch bases with that patient, who should go in first, and just plan for the whole visit. We also discussed the patients they were seeing the previous week and provide any updates on the needs we had in the treatment plan. Our wraparound care staff receive clinical supervision every week. We use a reflective supervision model of care. So we do a lot of, I guess, if you want to call it, planning together.
There's a question in the Q&A. I know Liz is typing in an answer, but I think we can address it as well. So the behavioral health and social determinants of health screening. So we were very intentional about the screenings we picked. And we are happy to provide, there is publications that will be coming out really shortly that detail the screenings that we've chosen and why we have chosen them, and then how often they happen. They happen upon initiation to the clinic. And so depending on how recent the birth is, we do behavioral health screenings, either the EPDS or the PHQ-9, as well as we screen for anxiety, we screen for PTSD, we screen for intimate partner violence, and then social determinants of health. Those happen at least annually. And then for the children, our developmental screenings happen on the well child schedule as appropriate.
Okay. Now, many pregnant and postpartum women with mental health issues go undiagnosed and untreated. Depression is the most common morbidity in pregnancy. Up to 50% of individuals with postnatal depression are never detected. Postpartum depression affects about 1 in 3 low-income mothers, and over 40% of women experience depression may experience recurrent episodes in subsequent pregnancies. And sadly, suicide accounts for about 20% of postpartum death, and it is the second most common cause of postpartum women. As far as the behavioral health prevention in a two-generation clinic model, we target three preventions. The primary prevention is the patient education about mental health, wellness, and problems during postpartum period. We provide mental health services to all patients when they need it and when it's convenient for them. This means that we are there in the clinic, and if we identify a patient that has behavioral needs, and that we go in right after the visit and provide the services. And we don't refer outside unless they need longer term services, then we refer to those patients to outside providers. The secondary prevention is a screening for comprehensive mental health and social care needs. Information, and we provide information on different mental health resources, the suicide and crisis lifeline, the maternal health, the maternal mental health hotline. And then thirdly, the prevention is the treatment and counseling in the psychiatry, the support that they receive to prevent reoccurrence of symptoms. This integrated behavioral healthcare blends in one setting for both medical needs and behavioral needs to better care for the whole person. The integration of behavioral health into primary care results in multiple benefits and improves outcomes such as improvement in health outcomes, enhances access to care, more convenient for patients. It improves quality and coordination of care. It reduces stigma and lowers health care costs. These are the screenings that they receive. Again, health, they receive medical screenings for chronic conditions such as hypertension or diabetes. The reproductive health, we always tell our patients that we want them to have the family they want and when they want it. So we work with them closely and respect their decisions. Behavioral health screenings, we screen for depression, for post-traumatic stress disorder, for substance use, for mental health history, interpersonal violence, community violence, discrimination, social determinants of health, such as housing instability, food, transportation, utilities, healthcare, finances, legal assistance, and as well as any natural supplies. And like Dr. Warner mentioned before, this happened at different times. The depression screening, it happens every time they come to a visit, either for the moms or for the children. And the other screenings are done in an annual basis. So, and children receive screenings, medical screenings, physicals, like yearly physicals. There's screenings for feeding to make sure that they are gaining the appropriate weight, safe sleep. We provide information and education on that. And as far as the development screening, we use the ASQ3 to screen for developmental milestones such as cognitive, social, and emotional, speech and language, fine motor skills, gross motor skills, autism, and spectrum. And for screen for autism, we use the MCHAT. So in the clinic, all mothers and children receive comprehensive behavioral health development screening. In clinic, contact from a social worker as often as they need it, parenting education, support to facilitate attachment, psychiatry if needed, and offer counseling with a social worker. In addition to postpartum depression counseling services, our patients are currently receiving counseling for mental health diagnosis or issues such as, but not limited to, anxiety, post-traumatic stress disorder, substance use disorder, bipolar disorder, grief, trauma, sexual assault.
Thank you, Aida. So we'll go through some of our initial results. So we have served 92 mothers to well, this data is a little bit dated, but the last time we collected our data, 92 mothers, the average age was 27, but ranged from 15 to 43. As you can see, a variety of race and ethnicities have been served, primarily non-Hispanic or Hispanic families. 45% of these mothers have been employed and 19% have been married. And as you can see, so the number of children, primarily these are newer mothers that have joined our clinic with just one child, but as our clinic ages, this has been actively changing. And I would say to date, if we redid this, our number of families with 2 or more children will have increased, as many of our families have decided to stay within the 2-generation clinic for future care. Comorbid health conditions that are not mental health based include very common things that you see within the antepartum and postpartum period, including hypertension and diabetes. Again, we screen all families as possible. So obviously the goal is 100%, maybe slightly below that, but upon enrollment, over half of our families receive at least one session of counseling with one of our social workers. Up to a fifth of our patients receive a psychiatrist visit with myself. About half of our patients receive some lactation counseling, and so we have a community health worker as well as a nurse practitioner who are both, in addition to those roles, also certified lactation counselors, and help our families with achieving their lactation goals as appropriate. We also assist our families both with our social workers, our nurse practitioner, and our community health workers linked to social determinants of health resources. We encourage breastfeeding as much as appropriate, given the health of the child. And then we also aim to prioritize making sure that the infants have up-to-date well-child visits, including immunizations and developmental screenings. Like we had identified, so we do a variety of screenings upon admission to the 2-generation clinic, and then repeat them as needed based on the results of the screenings. But for all families, they are repeated annually if they don't need to, if they are negative upon admission to the 2-generation clinic. So we have about a third of our patients have a positive screening for depression or anxiety. About a third of the patients also have a positive screening for intimate partner violence. About 15% of our patients have positive screening for post-traumatic stress disorder. 10% have a positive screening for substance use. And a majority of our patients have a positive screen for any type of behavioral health condition. 100% of patients with positive screenings are offered immediate counseling services with our licensed independent practitioner social workers, which includes AIDA, as well as additional social workers within the clinic. And the majority of those patients that have a positive screening engage in those services when offered. And then over half of our patients with positive screenings are also referred to myself for psychiatric services and medication management. So Aida and I are both going to talk about, we have 3 cases that we're going to go through. These are not the real names of the patients, so we have de-identified them, but the general principles of these cases are accurate. So we have Ashante. She is a 40-year-old Black female. She's 5 months postpartum. She was referred to the 2-generation clinic by her primary care provider. Almost much earlier than 5 months. She was referred within the first few weeks postpartum. During her intake process, she reported experiencing significant symptoms of anxiety. She reported she delivered at the same hospital that the 2-generation clinic is housed in, which is the University of Illinois Chicago Hospital System, but felt unheard by her OBGYN providers. She had developed preeclampsia, and her infant was IUGUR, and so it was recommended that she had a C-section. She felt that she was unheard. She had not wanted to have a C-section, and she had expressed that she didn't feel like her reservations about the labor and delivery plan were heard. She had a significant history of post-traumatic stress disorders outside of this, including a sexual assault within her neighborhood when she was younger, and then also witnessing the murder of her brother via gun violence, and felt that her experiencing delivering her infant re-traumatized her. So she had symptoms of fatigue, feelings of losing control, insomnia, irritability, racing thoughts, shortness of breath, sweating, difficulty concentrating. She also had feelings of worthlessness and guilt. So she was scheduled with me, we, as well as our nurse practitioner and lactation consultant. She also wanted to make sure she, if possible, could successfully breastfeed. I diagnosed her with PTSD. We came up with an appropriate medication plan where she would be able to breastfeed. And she continued treatment with me, with one of our social workers, and with our nurse practitioner lactation consultant. Another example case is Alexa. She's a 27-year-old 2-month postpartum woman, mother of 2 children. She joined our 2-generation clinic after experiencing psychosis following the birth of her first infant. So she had really almost more like OCD type symptoms of psychosis, and we were successfully able to start her on an SSRI, and she readily accepted the ego dystonic nature of her symptoms, which is why we were comfortable with labeling some of her feelings of hypervigilance over her children as more OCD in nature than of true psychosis. And so with her first child, we started an SSRI. She went into remission quickly. This recurred after she had her second child at around the same time, 2 to 3 months postpartum. And our Aida, as our behavioral health care manager, just as a normal touch point with our patients, was able to readily identify that these symptoms were reoccurring, and we were able to treat her quickly upon the birth of her second child. Rita, I don't know if you want to add anything else.
For this case, no, I think that she also had a lot of insight. Yes. And we worked together, and she was able to accept the services more than anything and say, no, I want to plan, I want to be ready for this second baby. I don't want the same thing to happen to me. So I think that she was very successful in avoiding a second hospitalization.
And then Jacqueline is a 24-year-old 4-month postpartum woman, mother of 2-year-old and a 4-month-old baby, joined the 2-generation clinic 3 months after giving birth to her first child. During her intake, she reported experiencing symptoms of depression. Additionally, she reported experiencing depression and anxiety when she was 11 years old. She received counseling services intermittently in the clinic for 1 year. 2 months after giving birth to her second baby, she reported feeling increasingly sad and anxious, had a hard time bonding with her baby, and having intrusive thoughts. She again was scheduled with myself. Subsequently, we had diagnosed her with postpartum OCD and PTSD. She also was experiencing intimate partner violence, and then had separated with the father of both of her children, which was both difficult, but a significant positive that we could help support her through that separation, through both meeting with me, but also meeting with our social workers within the clinic. And she continues to receive care by both myself and our social work counseling services. So as far as future directions, like I said, we have a number of manuscripts that are going to be published within the next 12 months. So we are looking forward to examining our 2-generation clinic patient outcomes as compared to usual care within the University of Illinois Chicago healthcare system. We would like to look at improving maternal health through an adaptation of a 2-generation postpartum care model in diverse settings. So we have an overview model of the 2-generation clinic, which is senior authored by Dr. Liz Glasgow. I am authoring a paper that focuses on the behavioral health integration within the clinic. And then Dr. Sam Wainwright is the lead author on a paper that focuses on how we have intentionally also included paternal mental health within the 2-generation clinic. We have a number of presentations that have been given statewide and nationally, and our goal really is to spread this model to other health system and populations. We are actively exploring and applying for funding to replicate the model as we are able. I really do think that having real-time access to therapy and psychiatry has been very impactful for our mothers. And I think Aida can speak for that as well. So most of these moms, if they need psychiatric care, are seen by me within a week of when the need arises. And then if they need therapy, it is, I would say almost instantaneous. And I understand the uniqueness and the of this model and how impactful that can be, and really wish that we can through these publications identify how this can really be in a long-term and cost-saving mechanism, and really help women and their children with achieving positive healthcare outcomes.
We are providing a list of lesson learned examples in the chat, just in interest of saving time. We want to thank all the people that are involved in the clinic, the doctors, all the staff. These are the people that make it happen. Thank you, everyone. I'm going to stop sharing my screen so we can answer any questions that you may have.
I'm going to say, so for how do you screen for anxiety? So we use outside of the EPDS, we use the GAD-7. We also use the PCL5 and for PTSD, and then our intimate partner violence screening is the EHITS extended version. And in Dr. Glasgow's paper that will be published shortly, it includes the details of all the screenings and why we've chosen them. And I discuss this in my paper as well.
Okay. Any more questions? Well, thank you, everyone.
I think Liz, Kimmy, and Camilla. Liz is trying to answer, and then
So
Jimmy.
do you want me to talk about the cost effective?
Mhm.
We believe it's cost effective because we have avoided hospitalizations. However, on the other hand, we are very high touch, which means that we have a lot of staff that provide a lot of care. And so that, that isn't necessarily cost effective, but it really contributes to outcomes. All of our patients are insured. Most have Medicaid. To establish an appointment with us, we either, if they don't have Medicaid or insurance, we help them get that and then make the appointment.
And Jimmy asked, are we seeing any differences in outcomes between younger and older clients? That is a great question. We have not specifically investigated that. I think one of the cases we shared was of an older client who had not had children previously. She was 40 when she delivered her first child. It was in a very planned and intentional birth, and she felt very, how she got to us was that she had felt very unheard by the healthcare system during her antepartum experience. But we haven't delved into other patients like her compared to our younger clients, which I would say that the majority of our families tend to be late teens and 20s.
Yeah, and I want to say that we identified that those younger of our clients have a lot more needs, and so we do kind of provide more education for them, and with everything, right? Even how to hold your baby, how to feed your baby, how to change your baby. So there's a lot of education that goes in with younger clients.
Thank you, everybody.